Thanks, Manoj. Thanks, Makar. And morning, every one of you. Respects to my chair and senior colleagues. It's an honor to be giving this shalom. Well, the topic that was actually assigned to me uh, by Banshi in the scientific, they said this, it's complicated, taking lessons from the past and the present to build a future free of diabetes. And you all heard Dr. Antonio. Well, I would like to start by saying something that all of us already the multifactorial influenced by genetics, lifestyle, environment, and of course, socio-economic factors. This is something that we should never forget. Well, as my teachers always said, look, diabetes is not just blood sugar. Diabetes is the web of complications. And every meeting, I've been talking about this complications, how to prevent the complications. We just heard about the cardiovascular, one of the experts in the Dr. Antonio doing so much of research, Milano. The question now is the web of complications, what do you need? Okay, if I go back, I'll start using some of the slides which I always loved. You need a Spider Man. Well, web of complications, Spider Man, I think you need to be more than a Spider Man as doctors to really prevent these complications. And look at this big burden. I'll talk about India and the bitter truth in India. And I don't have to go beyond this particular study. In fact, yesterday at the convocation lecture, Dr. Mohan did mention of this. This is the kind of a burden. Just look at this. 101 million. Let's not forget the fact that every sixth person living in this world population today is an Indian. And when you look at the diabetes burden in India, it's 101 million, which is almost 12% of the population. If you look at the pre diabetes burden, almost 136, that means another 15%. And you have dysglycemia, you have hypertension, you have obesity. We have a lot more. And I just added this author note yesterday after I heard Dr. Mohan using HbA1c in addition to OGTT for diagnosis led to nearly half the population being diagnosed with dysglycemia. And Dr. Mohan mentioned this, and the use of ADA cutoff led to a near doubling of the prevalence of pre-diabetes compared to WHO criteria. I just added this. So this study therefore used the OGTT and the WHO criteria for estimating the prevalence of diabetes. It's so asymptomatic. I think we need to do some kind of a pan India study to really get where are we. We are not proud of being called the capital of diabetes. And these are the projections as per the published data, and this is the huge burden. Now, we all are Spider-Mans, I said. I think it's time to wake up. I don't think the Spider-Mans can be sleeping, especially in India and worldwide. On a lighter side, I said, okay, I mean, the burden is huge and we have to do something. But then in between, we also need to relax the mind. What's happening in India is this. We all know about the Mahakumbh. And we know whenever we go for puja and things like that, it's very customary for the pandit or the priest to ask, what is your name, what is your star, and what is your gotra? And then they perform the pujas. I, I think these days are gone. Especially in India, if you want to go for the puja, probably the day will come when the priest is going to ask you, okay, what type of diabetes do you have? What type of lipid levels you have? What is your BP reading? What is your waistline? What is your BMI? You know, days are not far off. So we have a huge problem in it. It is worldwide, but I'm concentrating on India today. We come to the complications of diabetes. And when it comes to the complications of diabetes, especially the retinopathy, neuropathy, nephropathy, we may not have a pan India data, but believe me, data is available from most of the major cities or centers and things like that. What we kind of know is more than 30% of our patients will have complications definitely after 5 years or 10 years. We did a few studies from Diabetes India called the PODIS was the first one, and then later on we did Cindy, and then we looked at complications at diagnosis among the Indian patients. And we picked up almost 15% to have hypertension at diagnosis, 6% to have retinopathy. But we need to replicate this kind of a data. And this is the complication at diagnosis. So let's go back to what we have learned from the past. I cannot be going into the details of each one of the studies, but we have learned enough from these studies. In fact, Dr. Antonio in his key note address did mention about a few of the studies. Well, the important thing is most of the mega trials in type 2 diabetes were very exciting when we were waiting for the results, but turned out to be a little bit of a frustration when we actually got the report. The frustration because we all thought that good glycemic control can actually reduce the complications, and that did not happen. Well, it did improve the microvascular complications. Too tight a control in some of the trials also led to death. And we also learned that you had to start early from day one when you see the patient. You start late, you're very unlikely to prevent any of the complications. And then, of course, there was debate on the importance of glycemic control, preventing macrovascular complications. And with that, there were a lot of arguments till 2016 when we started getting more and more trials, and you will be hearing so much about the CVOT trials and the good drugs and the cardiovascular benefits, etc. So I will not go into details of that. The important thing was there was a lot of concentration on the prevention, and I have just listed, trust me, these are some of the prevention trials. I have listed just 10% of the prevention trials here. If you actually go into the database, you will find at least 70, 80, 90 different types of prevention trials that has gone on worldwide. Everybody wants to prevent diabetes itself from getting into the. Now, this is what the whole thing is looking at: how to reduce obesity, how to make people start exercising, how can we make people stick to a regime. We sometimes forget that there is a human mind which is different in one of us, which is actually acting. We only think like scientists, we only think like doctors when we think of the prevention trials. What are the key take home points from the prevention trial? Lifestyle intervention. I mean, if you take all the trials, 50 to 60% of the reduction came from the lifestyle change. And of course, there were medications like metformin, acarbose, pioglitazone, even rosiglitazone in cream trial, etc. However, we can use them in pre-diabetes in certain cases, but not in all of them. Well, this is a fantastic paper that came out. I think efforts of Manoj Chawla, Dr. Ramachandran, and the Diabetes India group and the prevention thing. And then you can actually look into this call to action for clinicians in Southeast Asia region, a consensus statement. And it's very clear today, diabetes is not just blood sugar, it's turning out to be cardiometabolic, renal and vascular in approach. There have been three eras. The first era was glucocentric. The second era was glucocentric, plus no hypo. Well, let's not have a weight gain because that can actually add to the complication. And the third era, that's where we all live today, cardiometabolic and renal approaches. Number one, number two, plus end organ protection with a focus on cardiorenal outcome. And this is where we are. And now we are moving into an era where it's just not this, but also obesity management. I'm sure in the next 5 to 10 years, the concentration is going to be on obesity management, obesity management. Now, we know the present day. You know, I find it very funny because each year there is a happy doctor's day. So many of our pharma colleagues come with flowers, they come with greetings, and sometimes a small little gift, and then they keep saying, Happy Doctor's Day, Happy Doctor's Day. Until today, I don't know what is that Happy Doctor's Day because it is just been work, 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 work. And if you're in the space of diabetes today, and if you're serious about seeing your patients without complication, trust me, it's going to be more work, more effort, and half effort does not produce half results. In fact, half effort produces no results. So we need to be working very continuously, a lot of hard work, and that's the only way to accomplish this particular dream, to see that your patients are fine and you're not going to have complications in future. And everybody knows about this comprehensive care today. Why did ADA arrive at this? Why did EASD arrive at this? Because everyone realized, oh, look, it's just not writing your prescription. It's just not giving a little bit of education. And it turned out to be much, much more than that. So we'll not go into the details of it. Today, what we really need to do, each one of us, is a very organized care model, and that's what is necessary. And that needs infrastructure. You need to have a care team that needs staff and equipment. Cost planning is very, very important. Training of the team is very important. Multiple jobs given to team members. We need to plan scalable models if we are serious about prevention of complications. And a planned care brings definitely the return on the investment, no doubt about it. And then the patients prefer today a one stop shop. It's very difficult for me to say, okay, now for this you go here, for that you go there, for this you go here. No. Malls are an example where every area has a new mall in India and every mall is doing well because people get what they want. So I think the future in India is going to be a one stop shop, a care model for diabetes. Now, let's ask a question ourselves. Are days of one person doing all gone? You know, the senior doctors, the professors used to sit in a clinic. I'll give 8 appointments, 10 appointments a day. Now, the thing is, if you are serious about treating your diabetic patient, I think this one person do all days are probably gone. Medication prescription is just a very small part of the comprehensive care, and I was very happy Dr. Antonio did mention that. It's not just writing the prescription or adjusting the, and that just takes 5 minutes. A constant education regarding your diet, exercise, motivation, SMBG, food care, and most important, the medical record. Because talking about diabetes to the patients become monotonous, sometimes the doctors take it very, very easy. And that's when we do the errors. Well, we need to use referral labs, we need to have eye exams, other specialist care, and the patients today demand a very high level of comprehensive care, and that too in the shortest period of time. And this we have to realize as doctors, that are we ready for this kind of a thing? I think team building is the backbone of the patient care. That's something that we all have to do in our own small setups. In super specialty hospitals, it's become a very shared responsibility. I put up this particular photograph using the AI, trying to show the doctors that in many of the super specialty hospital, well, you don't see too many white coats sitting in this particular room. planning the strategy and things like that. It's all young minds from different fields. All right. So doctors also become a part of that system in India. It's a shared responsibility today. The doctors, the patients, the support staff, and many other stakeholders get involved, especially in the management of diabetes and complications. We need to worry about the healthcare structure, the insurance, the pharmaceutical and the medical device companies. Everyone has a role to play. There's a public health and the media support. There are policymakers, research and academics, schools, educational institutes, and of course the technology providers. All have to come together. It's just not learning about good drugs, it's just not learning about good insulin use. I think there's a lot more if we have to see each one of our patients without the complication. I thought that was too much, so I will just break it with one small little side. On a lighter side, not many can really guess what this particular thing is. I just wanted to bring in the point that caring for a person with diabetes is really complicated. It involves a number of things. And I found this on the Google. And this is supposed to be a Mexican sauce, and it's called mole poblano. I had not heard of this. It's a sauce typically made of 20 different ingredients and said to be the most complex to make, supposed to take about a week. Of course, we don't need 1 week to treat. Sometimes it needs 3, 4 days to evaluate a person with diabetes. But then this is just to tell you that yes, number of things are needed. It's just not us. Well, this is what we want, a vision which is complication free for the future. We have to dream of this. Dreams are not bad. Unless we have a dream, it's told that we may not try. So we must dream, we must try. Whether we succeed or not is not important, but the effort must go on. First, I tell my colleagues and my junior doctors in Bangalore is look, don't try to be someone else that you are not. Just know your patient segment. Whom are you catering to? Just because there is another gentleman who can sit in a big place and write expensive medicine, you cannot be able to do it. So, know your patient segment. Please revisit the strengths and weaknesses. See where you practice clinic, hospital. You are in an academic side, non academic side. Are you into research, clinical, translational, basic science? Very few can actually do all this. I don't want to take the names, but there are a lot of all rounders in India. But we as individuals must actually look at our own strengths. And where necessary, I think technology is something that we have to use. This is something that many people have not been using. Well, just when I was preparing some of these slides and things like that, in fact, Dr. Banshi sent this particular paper across, and then it came in the group, and I thought it's a very, very interesting paper. Digital health technology in diabetes management, Asia Pacific region, a narrative review of the current scenario and future outlook. Yes. So use the technology. And the most important thing is the electronic medical records. This most of our doctors have not been using. If you're serious in diabetes, you have to have your EHR. Well, there are limitations about telemedicine and online now, but during COVID, it helped us a lot. So, when the time permits, I just want you to read this. The digital health technologies offer very promising solutions to bridge many of the things. Well, you need to prevent complications. When we talk of retinopathy, we think of blindness. 40 million people blind because of retinopathy in this world. Okay, now evaluate for diabetic retinopathy. The only complaint was, I don't know how to do. I think keep the fundus photographs at each visit, follow the guidelines. If there is no diabetic retinopathy, once a year, mild to moderate, once in 4 to 6 months, PDR or DME, refer ASAP. Can learn, every doctor can learn to use a direct or an indirect ophthalmoscope. But today, highly cost effective funders on phones and AI is available. I just thought I'd just show you one particular slide. Diagnosing DR is a child's play today with a very, very high level of accuracy using the AI. And this is offline, highly cost effective, and available for less than 2.5 lakhs in India. Okay, and it gives you the diagnosis within 15 seconds, and this has been a game changer. And this approval has come in India, it is there in Singapore, it's just waiting for the FDA approval. But the Funderson phone is approved by FDA. So this is something that we all can use. It's not difficult and not expensive. A good clinical examination, my teachers always told me, trust me, you don't need equipment. A good clinical examination, using your hands, you can pick up the vasculature, you can pick up neuropathy. Well, if you also want to use, you have hand Dopplers. These are not expensive in a country like India. Everybody wants to have an ECG machine. Well, it's like that. It's very simple to have a biochemistry analyzer. If you're setting up your own lab, and one of the most recent ultrasound echo Dopplers and a CBC machine, and you have a point of care for urine, microalbuminuria, and you have highly accurate HbA1c. Trust me, setting up your own lab in India today, if you have enough of space, is less than 30 lakhs. For all this, you don't have to have a very high level lab. And we have sessions on CGM and insulin pumps. I know it's extremely useful and very necessary in the type 1 space, but the usage is limited to the affordable class right now in India. But that is something that we need to change, and I'm sure Diabetes India is working towards that. It's very difficult to prevent complications in a type 1 if you are not serious about pumps. Even 4 times, 5 times insulin, it's been extremely difficult. So, following up of the patient, I think, is the key success, and this is where your mobile phones are going to help you a lot. Your WhatsApp messages are going to help you a lot. Keep sending a reminder to come back for a referral every 3 months or 4 months. Send it 5 times, and they may come back after 6 months. We must have a system to call back the patients for follow-up, and this is a problem in a country like India because it's free shopping. They can see 4-5 doctors in the same week. That's a system we need to see how to change, but that's very difficult. Electronic health record, I think, is a must. And important thing is, I request each one of the doctors to audit their own self with respect to each of the. Did I bring down the BP? Did I bring down the weight? Did I bring down the HbA1c? Each patient, not overall. Please don't try to be a dietitian yourself because your intelligence is needed at other age. You need to have good dietitians, mental health experts, and physical trainers, along with nurse educators and junior doctors. And training the staff is what we need. And you people have already been doing it in India and done it very, very successfully. And one last word, don't chase success. Please chase the satisfaction, and success will come with the rest of the things. And one bad habit that we all have as doctors is to do multitasking. Okay. And I used to see Dr. Shashank doing a lot of multitasking before. Now I see Banshi doing multitasking. Okay. And very few of us can do that, and very successfully we can do that. Right? Let's know our limitations. We can't be someone else. We have to be ourselves. Okay, on a very lighter vein, I've used the word the donkey derby because sometimes we do stupid things in trying to ape others and trying to be someone else whom we are not. So, this is where I am. I have 1 minute left. Let's understand where we are today when you start to see patients or people with diabetes. Well, we know life is a competition, but you don't have to be in the competition. You have to balance it out. Many a times, and this is something that I picked up from one of the hospitals which specializes in Ayurveda care and things like that, translated to English. In an effort to have a better tomorrow, we are forgetting to live today. May be true. Okay. So we sometimes overwork. We try to do too many things. Okay, we may not be experts. So in an effort to have a better tomorrow, let's not forget to live today. And this I picked up from actually my mentor and a good friend, Dr. Prasanna Kumar, said that, Arvind, if all the doctors end up working for 14, 15, 16 hours and you want to be doing conferences, you do this, do that. Okay, we're all doctors who are living poor and we're going to die rich. Okay, so this is something that we all have to practice. So my last slide is, while a future completely free of diabetes complication might be a dream, aspiration, dream, but it's a dream worth striving for, and each step we take today brings us nearer to turning the dream into a reality for our patients. And thank you so very much. And I would like to really thank Dr. Mohan and Dr. Ramchandran and Dr. Mohan's father, Professor Vishwanath. Uh, I started my hospital after the training in their place under Dr. Mohan's father and others. And it's 34 years, and then I've been continuing diabetes practice. Thank you so